So yeah, no, it's a great honor for me to be invited to speak. So thank you very much to the coordinating committee. As James mentioned, I'm a stream leader of the pituitary medicine stream at Royal Melbourne Hospital and co-chair of the Australian New Zealand Pituitary Alliance, which we're setting up to do similar things to this to help foster education and research into pituitary disease in Australia and New Zealand. So it's a great honor to be invited to present today. And I'm sure, you know, this audience is quite aware of Michelangelo's keenness on anatomy. And it's interesting when you look at the brown cloak surrounding God here, and you can see the distinct outline of the brain, and the little cherub's leg may well be a good representation of the pituitary gland. So pituitary adenomas are something that we really enjoy working with. Prevalence of about 78 to 94 per 100,000, with about 50% of those being lactotrophonomas and 30% of gonadotrophonomas, about 15 to 20% somatotrophonomas, 5 to 10% corticotrophonomas. Thyrotrophonomas, we've studied the genetics of in our group, but are very rare, less than 1%. And then we do find about 30% plurihormonal, secreting usually a combination of growth hormone prolactin, but plus or minus thyrotropin. Don't need to speak to this audience about the mass effect symptoms, but this paper from India in 2012 really does show how quickly the bitemporal hemianopia can resolve with dopamine agonist therapy for a prolactinoma. You can see after 6 weeks, a quite significant bitemporal hemianopia resolving with tumor shrinkage for post-dopamine agonist commencement. So as an endocrinologist, obviously we are concerning ourselves with hormonal excess and deficiency problems. Prolactin excess obviously causing amenorrhea, hypogonadism, galactorrhea, breast growth and tenderness. Growth hormone excess, depending on when it occurs, if it's pre-epiphyseal closure, it will cause gigantism. Post-epiphyseal closure, acromegaly, ACTH excess, obviously Cushing's disease, TSH excess, thyrotoxicosis. Prolactin obviously can be a bit tricky when it's at the low levels because it can be attributed to multiple pathologies. So levels more than 2,000 milliinternational units per litre is usually associated with a macroprolactinoma. But microprolactinomas, other pituitary disorders causing stalk effects, pregnancy stress, and numerous medications and other drugs can cause elevations in prolactin to a certain level less than 2,000, which needs a little bit of diagnostic sorting out. Acromegaly obviously causes the classic enlarged jaw, hands, feet, and coarsening of the facial features. We also see macroglossia and some visceral metabolic changes like cardiomegaly, myopathy, hypertension, diabetes, obstructive sleep apnea, and osteoporosis, which is quite significantly a prominent vertebral osteoporosis, and they're prone to fracturing that area. And tumors can be associated with increased risk, such as colorectal and thyroid tumors. As you can see here in the images, the classic spade hands, macroglossia, frontal bossing, and prominent jaw. Cushing's, on the other hand, causes a myriad of symptoms which occur with various frequencies, from central obesity almost always, to facial plethora, which I find a useful sign of active Cushing's, diabetes, proximal myopathy, hypertension. Psychological changes can be quite prominent, and osteoporosis, again, predominantly affecting the vertebrae. There are obviously many other symptoms and signs of Cushing's disease, and they have various sensitivity and specificity in terms of diagnosing that problem. You can see here a classic sort of representation of the facial plethora when the Cushing's is active, that settles when it's treated. We obviously worry also when particularly there are macroadenomas about hormonal deficiencies. LH-FSH deficiency obviously will cause hypogonadism with amenorrhea, low libido, erectile dysfunction, or absent secondary sex characteristics. ACTH deficiency can cause fatigue, postural hypertension, and cognitive decline. TSH deficiency, obviously hypothyroidism and antidiuretic hormone deficiency causing diabetes insipidus. So microadenomas really rarely do cause hypopituitarism, but macroadenomas generally about 90% will have at least one hormone down. And the prevalence increases as the tumours grow. And this is actually due to mostly compression of the portal vessels in the stalk, due to either direct pressure or that raised intracellular pressure. And we have a typical sequence of loss of hormones with growth hormone first, followed by LH, FSH, TSH, and then ACTH. The central localization within the pituitary gland of the corticotroph cells does preserve their function, which is perhaps a survival advantage with that. So when we go to look at assessing pituitary patients, we will obviously check the pituitary hormone and then the end hormone to see whether the function's adequate. So ACTH and cortisol at 8 a.m. To check that axis. And if there's signs of ACTH deficiency, we'll consider an insulin tolerance test and sometimes a Scholz-Tinactin test. If there's signs of Cushing's syndrome, they need a screening test for Cushing's, and that could either be 11 p.m. salivary cortisol, a 1 milligram dex suppression test, or a 24-hour urine cortisol. For the thyroid axis, we're going to be checking TSH, T4, T3, gonadotrophic axis, LH, FSH, either with estradiol or with testosterone. We'll check prolactin, and it's worth noting that with very high prolactin levels, you can actually get a problem with the assay, the sandwich immunoassay, and so dilution may be required to exclude a hook effect in macroprolactinomas. Somatotropinomas, we check growth hormone, and we also check the IGF-1, which is a better barometer of long-term growth hormone excess, as growth hormone is a pulsatile hormone. And if we're worried about growth hormone deficiency, we can use the insulin tolerance test, but more often at the Royal Melbourne, we find the glucagon stimulation test to be an easy and well-tolerated test. If we're worried about growth hormone excess, we'll do a growth hormone suppression test with 75 grams of glucose, checking growth hormone at 1 hour and 2 hours. And for diabetes insipidus, we can do a paired urine serum sodium and osmolality. If they're not hypernatremic and that needs further validation. At the Royal Melbourne, we're often doing an arginine hypertonic saline copeptin test these days instead of the water deprivation test, which takes potentially all day long in the low-risk patients to rule out the disease. If you're ever interested in looking at some of these tests, the Endocrine Society of Australia has a link to them. We have a few eminent endocrinologists, one who I work closely with, Sri Chang, who came up with this harmonization of endocrine dynamic testing, which is on the Endocrine Society of Australia website using that link. And you can access things like that copeptin test I just mentioned. So with Cushing's syndrome, it's worth understanding that about 1 in 3 24-hour urine-free cortisol levels will be normal, even if you've got Cushing's disease. And that led to people thinking about what other tests can provide a better test, better sensitivity and specificity. And a blood test at 11 p.m. or midnight is actually pretty hard to come by, but if you could, a level less than 50 would pretty much exclude Cushing's syndrome. A level greater than 207 would be excessive Cushing's, would be indicative of Cushing's and excessive cortisol, and exclude pseudo-Cushing's. And that's led to us looking at the role of late night salivary cortisols, because this actually represents the free cortisol level and can be collected at home. Also, obviously, we do a lot of 1 milligram dex suppression tests, with the cutoff being less than 50 to exclude Cushing's. And if Cushing's syndrome is proven, then we want to know the ACTH level greater than 4, indicative of ACTH-dependent disease. And then we're wanting to rule out ectopic disease, and you can do either a high-dose dex suppression, a CRH test, a dex infusion test, an MRI pituitary, or a CRH-stimulated petrosal sinus sampling where indicated. It's good to reflect where Cushing's usually arises. About 70% of Cushing's syndrome will be pituitary Cushing's, and only 10% ectopic ACTH, 10% adrenal adenomas, with adrenal carcinomas, ectopic CRH much less likely. And in particular, in your young patients with pituitary tumours, it's worth recognising that about 7% of pituitary adenomas potentially have a genetic syndromic basis. And it's worth knowing about those conditions, because there are associated tumours that could potentially be prevented or treated early. So then it's over to you guys to do your amazing work. And then we look after we particularly focus on a few things post-operatively. So hypopituitarism can resolve with that reduced pressure on the portal vessels, and we see recovery in at least one pituitary axis in about 50% of patients undergoing transsphenoidal surgery, with recovery usually within 2 to 3 months, but sometimes delayed out to 12 months. Particularly, we see sometimes the gonadotroph axis can take a while to normalize. Hypopituitarism will persist if the compression of the portal vessels actually caused ischemic necrosis of the pituitary. And new hypopituitarism can obviously develop if there's been manipulation or damage to the pituitary, and that's obviously impacted by the size and invasiveness of the tumor and also surgical experience. We mostly concern ourselves in the perioperative period with diabetes insipidus and whether there's a need for glucocorticoid replacement. Diabetes insipidus is actually not uncommon to be, if it's transient, about 30%, but very rarely does it become permanent. We look for that by urine volumes of greater than 250 mils per hour for 2 consecutive hours with a very dilute urine with an osmolality less than 200 milliosmoles or a specific gravity less than 1.005. And we make sure our patients aren't restricted from accessing fluid, because if they have developed diabetes insipidus and you're not aware of it, they will simply drink, given they've got an intact thirst center to maintain their sodium in a normal range. But if fluid restricted, they can develop hyperosmolality and hyponatremia, which can be a problem. If diabetes insipidus has developed, obviously we want something that selectively binds to the AVPV2 receptor, because that reduces the polyuria without causing the AVPV1 receptor-mediated vasopressor changes. And we often give a PRN dose of desmopressin, 1 microgram subcutter IV, because we don't want to chart a regular dose, given most of these will be transient, and sometimes later people can become the other way around, hyponatremic. So with glucocorticoids, ACTH deficiency can be life-threatening, and so we want to take those people that come into the pituitary surgery with ACTH deficiency and treat them with hydrocortisone. We suggest a tapering regimen, given that it might improve post-surgery, with hydrocort 50 milligrams TDS day 0, 25 milligrams TDS day 1, 25 milligrams MANA day 2. And if there's no post-operative complications, we'll check cortisol level at 8 a.m. on day 3 to 5. If that level is less than 100, it's likely the ACTH deficiency will be long-term. Greater than 450, it's likely the ACTH axis will be intact. And so that leaves a grey zone, which I'll go through in a second. In Cushing's disease, ACTH deficiency is actually what we desire. And we want to be able to look at the cortisol level in those patients. So we selectively use dexamethasone, as that doesn't interfere with our cortisol assay, unlike hydrocortisone, which when we measure cortisol could be detected as cortisol. So we use dexamethasone 4 milligrams day 0, 2 milligrams day 1, 0.5 milligrams day 2, checking cortisol levels day 3 to 5. I mentioned before you can develop a transient hyponatremia on day 5 to day 10, usually due to SIADH, and cerebral salt wasting is a very rare thing that we see. Obviously, the difference there will be the patients will be massively hypovolemic as opposed to euvolemic with SIADH. The reason we look at the insulin tolerance test over a Short-Synaptin test in pituitary disease is that if we want to stimulate the hypothalamus and pituitary, we need a stress to do that. And the glucose level of under 2.2 will do that. It'll lead to increased CRH if it's possible to be increased, and increased ACTH as a consequence, which will then lead to the adrenal producing more cortisol. So we're looking for a cortisol there of 500 to 550 to show it's normal. This is compared to a Short-Synaptin test, which bypasses the hypothalamus and pituitary and simply just gives a synthetic ACTH dose to stimulate the adrenal and cortisol. So if the pituitary dysfunction is relatively new and the adrenal hasn't yet atrophied, which can take about 3 or 4 weeks, you may get a normal cortisol level post-synaptin, but there's still ACTH deficiency that's a problem. With regard to that grey zone of what to do with cortisol levels between the 100 and 450 mark here, this paper from a colleague Warwick India in Queensland from early 2000s shed some light. Levels of 100 to 250 nanomole per litre, we would generally replace with at least 10 to 20 milligrams of hydrocortisone and look at testing again about 4 to 6 weeks post with either an insulin tolerance test or a glucagon stimulation test. If it's abnormal, we'll go ahead and long-term replace them. If it's 250 to 450, those patients simply just need stress doses when they're stressing with medical illnesses. So then we'll go ahead and check a day 7 cortisol. If it's less than 350, those people will also need to go on and have an ITT around 4 to 6 weeks. If it's greater than 350, they're unlikely to result in a problem. So around that 4 to 6 week mark, we check all the other axes and start any necessary treatment. It's important to remember that we don't want to replace testosterone in a man who's desiring fertility in the immediate future. And we often send them to an IVF clinic where HCG is often given. That could be done in-house at various hospitals. With growth hormone, if a patient's got acromegaly, IGF-1 levels do not normalize until about 12 weeks, so don't look too soon because you'll be falsely disappointed. And if we're looking for ACTH deficiency, we'll generally prescribe about 15 to usually 20 to 25 milligrams of hydrocor per day these days, with about 2/3 morning, 1/3 at around 4 p.m. With the very low doses of around 15 milligrams, it's necessary to triple the dose in the context of stress and illness rather than doubling it. And we encourage a medical alert bracelet and IV hydrocor if oral intake is not possible. Now, while surgery does offer the best chance of cure of acromegaly, it's important to recognize that some aren't cured and that there's maybe a need for other treatments. And the medical treatments we'll look at using would be dopamine agonists, somatostatin receptor ligands, and growth hormone antagonists, and as well as radiotherapy. Cabergoline monotherapy is quite weak at controlling IGF-1 levels and growth hormone levels with rates of about 35% growth hormone lowering. Benefits generally limited to those that don't have a significantly elevated IGF-1 level, less than 2.5 times upper limit of normal. The first generation somatostatin receptor ligands like octreotide LAR and lanreotide bind to the somatostatin receptor 2 and can cause biochemical control in about 25 to 55% and tumor shrinkage in some due to direct and indirect anti-proliferative effects. And there are second generation somatostatin receptor ligands like pasireotide, which binds strongly to SST2 and SST5 and has better control rates compared to octreotide LAR and lanreotide. But this is limited by hyperglycemia, which can occur in up to 70% and can cause significant metabolic issues in itself. So we would consider that in patients who are uncontrolled with a first generation ligand, who have residual tumor mass that's not really suitable for resection. And then there comes pegvisomant, which is a growth hormone receptor antagonist. Growth hormone levels don't fall when you're on pegvisomant, they're just blocked from acting. So we use the IGF-1 to monitor these, and we can get biochemical control quite well in about 60 to 75% when it's used as a second-line therapy. And that improves the complications of acromegaly, including LVH or left ventricular hypertrophy, sleep apnea, and the concerns about tumor growth that have been reported in the large observational studies are sort of rare, basically. That sort of Nelson's-like syndrome is very rare, and we do see improvements in glycemia with people on pegvisomant, and we'll consider using that in people that have got pre-existing impaired glucose metabolism issues, who aren't candidates for more surgery or need an interim measure while radiotherapy or other therapies are working. So then it comes to what do we do about those that have persistent Cushing's after surgery? Well, generally, if there's residual tumor on an MRI, we would ask you to consider repeat transperinodal surgery because that offers the best chance of cure. If it's non-resectable, then we think about radiotherapy and a steroidogenesis inhibitor, which will be quite effective. But for very severe Cushing's, we'll need to proceed to bilateral adrenalectomy, and often without not too much delay to avoid significant complications. If there's just mild hypercortisolism, then we can consider things like the somatostatin receptor ligand dopamine agonist, which can cause a remission in a few people. I'll leave it there, but except I just wanted to give a little bit of a plug to Australian New Zealand Pituitary Alliance meeting. We've got our first live meeting on the 28th to the 30th of July. James is coming. Ben Yonker's there, a few other neurosurgeons, Nikki Martins and others are attending. I'm a co-chair of this with Anne McCormack. We've got several cases and research being submitted for presentation. We encourage you to log on to anspa.com.au and consider joining us there. Thanks for your time. I'm happy to answer questions. I'll stop the share.
Thanks very much, Chris. That was a great summary. Question without notice. Do you have any thoughts on the role of copeptin levels in the early postoperative period to work out DI and which patients are going to have ongoing DI?
Yeah, I mean, I think that copeptin, just for those that aren't familiar with it, is obviously measuring antidiuretic hormone. It's not stable. It doesn't provide a reliable measure, but copeptin has been used more and more recently as a good marker of antidiuretic hormone levels. Low levels in that immediate postoperative period, particularly in people who are developing hyperosmolality and hyponatremia, would be very suggestive of diabetes insipidus. I think, James, that I know Cherie's been doing a little bit of work about that postoperative level, but yeah, I probably haven't got a lot more to say on that right now, but I think it's something that we'll be using a lot more. And I think it depends if your hospital has the assay, but it's something that we find quite useful.
Thanks.
So there is a question in the question box about surgery averse patients, and what would you advise them for the Cushing's?
Look, we worry a lot about our patients who've got Cushing's disease. I mean, there's a spectrum of disease, isn't there? There's the subclinicals who go on and on without diagnosis for years. And then there's the very severe disease that you really need to get onto surgery very quickly to save their life. So I guess there's quite a spectrum of disease, but Cushing's disease really does need pituitary surgery to fix it. And if it's not cured with the first surgery, then often it's a second surgery is the best next option. Medical treatments, I would say, are often a bridge, but are often not long-term treatments, with the exception, obviously, of bilateral adrenalectomy, but then you run the risks of Nelson syndrome, and we've seen some tricky cases of that over the years. So often medical therapy for this is often a bridge while waiting for radiotherapy to work when there's no options for further surgery, or you know, it's a compromise, I would say. But we generally try and twist our patients' arms to have surgery.
Like acromegaly, when you can almost predict success or failure of your surgery within, say, 24 hours, how long does it take for us to do that in Cushing's?
Similar, you know, we really look closely at these with using dexamethasone postoperatively. We can look at the postoperative cortisol levels, which really do tell us a lot. Remember, we're aiming for deficiency here. We would like to see levels under 100, ideally on the next day after surgery. Sometimes it has been that we've had patients who are a tiny bit above there at the first day, but by day 2 they're lower, and those people have done pretty well. But yeah, we're looking for signs, and if they're being given Dex, by rights, their cortisol should be very low on that post-operative day. So if you've got Dex on board and a cortisol more than 100 on that next post-operative day, it's unlikely that the Cushing's is cured, unfortunately, and watch those very closely over the next few months.
Thanks. I think you are going to be with us for the rest of the program, so we'll have further
unfortunately,
interaction.
I can't stay, but I'm happy to take some more questions now, but I can't hang around, unfortunately. I've got to
I thought Ramesh had some interesting cases which will probably challenge you as well. But maybe if you can't be here, thanks very much.
Thank you.
My pleasure. My pleasure.
Well, it's my pleasure to introduce.
Enjoy the rest of the meeting. Thanks very much.
Thank you.
It's my pleasure to introduce Dr. Ramesh Nair, Mr. Ramesh Nair, as he's in UK. I suppose he is a lead for pituitary surgery at Charing Cross and Cromwell hospitals. And we met a few times, and he's very, very dedicated educationist as well. And I'm really looking forward to his presentation on management with the tips and tricks he's going to talk to us about in some of the cases he's treated.
Thank
Ramesh,
you.
please.
Thank you, Chandra, and thanks, Girish, for this invitation. I'm going to share my screen first. Girish had some strict guideline for me to try and do it a bit more medical, which I normally don't do, but I've tried to make it as medical as possible. Can you see my screen now? Yeah. So surgery for pituitary tumors, it's not a uniform approach. It's varying kinds of pathologies we treat. Even though it's a pituitary tumor, it could be a non-functioning tumor or non-functioning tumor. So it's a varied practice. So for example, this one is a young female in her 20s. I think she was 21, treated 8 years ago. I don't know, any of you can see anything on this scan here. She had this workup for Cushing's disease, and it was positive, and including the positive IPSS. We struggled really hard to find anything, and I often get very nervous about operating patients when you have an indeterminate target. So this is one of the problems with treating patients with very without an indefinite target. Just not only for Cushing's disease, also for acromegaly, and even for prolactinomas when you have to operate on medically refractory patients. Here, the suspected lesion was around the left corner over the carotid. Despite us attempting at least 3 operations, I could not cure. On the other hand, certain patients are quite obvious. This is a 41-year-old man treated in 2014, I believe, almost blind when I saw him. He was a cleaner in a restaurant. I'm not sure what he was doing there, but he almost blind, and came with a massive tumor. So the surgical challenges are different for each patient. One where you cannot really find a tumor, and you have really struggled to explore the gland and get a cure, surgical cure, which is not important for a functioning tumor. On the other hand, tumors which are big and invading into various places of anterior cranial fossa or cavern of sinus, you struggle to cure the tumor by removing it surgically, and also with the precaution to keep the other structures intact. So I just simplified some of the common cases I see surgically, both functioning. We've gone through the medical aspect of all these tumors. Cushing's adenomas could be small tumors, micro tumors, which you don't have any idea where the tumor is, and one cannot really depend on the scan sometimes. So we have to really tread very carefully in such tumors. And bigger tumors, invasive tumors, also we have to tread very carefully. Your aim is to achieve a cure, and one may have to carry out a radical operation. Unlike a standard non-functioning tumor, one will have to be more radical, even going extracapsular or even going intracranial, because as the previous speaker mentioned, the best chance of cure for such tumors is the first chance. And once you miss it, it's going to be really difficult. So often you end up going back and again to try and get a cure. And each time, as you know, the surgical technique will become more challenging. You have to, there won't be any landmarks. You have to depend on a lot on your navigation, but first time is the best time. And prolactinomas, normally we don't operate, but certainly there is a clear indication in many cases when the patient cannot tolerate the medication, when they don't respond to the medication, and also large tumors causing visual compromise in an acute fashion. And rarely we do see other kind of functioning tumors, including coming from the TSH producing cells. Non-functioning tumors, on the other hand, there can be a lot of dilemma. when do we operate? A symptomatic patient, do we operate them or not? And that depends on their size and various other factors. Some tumors tend to grow, and that may be an indication to offer them an operation. Obviously, patients who are symptomatic with tumors causing pressure on their optic pathways, or even the pituitary causing pituitary dysfunction, there is a chance that you might get some recovery of one of their pituitary axis with surgical treatment. And many patients who would like to start a family, there is an implication of having the fertility issues as well with this sort of tumors, and you may want to offer operation for this sort of patients. And this is another scenario where the neurosurgeon would deal with pituitary apoplexy, not only pituitary hemorrhage, which is standard apoplexy by definition, but also infarcted pituitary tumors, which we tend to see very commonly than the other one, because patients with a tumor which then infarcts will have a similar presentation with acute cranial nerve palsies. May or may not have any visual problem. So that is another debatable area where you want to offer surgery or not. Logically, from a surgical perspective, you would want to take out the pressure within the pituitary fossa. We assume that the infarcted pituitary swells up and pushes the lateral walls and damages the third nerve in the cavernous sinus, or the sixth nerve in the cavernous sinus, thereby causing the ophthalmoplegia. But many patients, many times, without visual compromise, we sometimes have refrained from operating these patients. And majority of these patients have recovered their function. So that is a debatable area. So it's whether to operate on such patients without visual compromise is something which we take case by case. And IPSS is a standard workup for Cushing's disease. And the lateralization by IPSS is not something which we cannot rely upon. You can see that the dominance of the inferior pituitary sinus can vary from patient to patient, and also the dominance of the jugular veins and smooth sinus can vary. And so thereby you cannot really depend on the site where the tumor is going to be if you don't see it on the MRI scan. And generally when we, I just couldn't wonder how remarkably similar the Australian workup and the perioperative management of such tumors is compared to the UK. We do have a similar kind of workup. And here, as we know, following the pandemic, we have the NHS is really struggling with the waiting list, and patients are waiting longer, and the theaters have not come back to the full function yet. So we, as neurosurgeon dealing with pituitary, we prioritize these function tumors as high priority, especially Cushing's and acromegalics. So we tend to categorize them as P2s, so that they get pushed, jump the queue and come to the front of the queue. And it's a routine practice when they get diagnosed with Cushing disease to start them on anticoagulation. This is the factor 10 inhibitor. And at least at the time of diagnosis, and then continued at least 3 months post-op once the patient is cured. Growth hormone adenomas, certain adenomas are more challenging because they invade into structures, invade into the clival bone, invade into the cavernous sinus. And again, one has to be really radical to try and get a curative resection. This is a young chap who was in his 30s, was working in a police force, and with invasion into the cavernous sinus and behind and also the dorsum cellular. This was all cleared up. And whether to use lanreotide, the somatostatin analog, which we've been talking about before, it depends on, generally we don't tend to use it if we can operate them fairly soon after the diagnosis, but for some logical, if for any reason we can't operate them soon enough, we may have to start them on this medication. Two things. One, there are certain cases where you could get some resolution or improvement in the size of the tumor, especially tumors invading the cavernous sinus may improve a little bit, which will make your surgical access a bit more better. That's been experienced. So certain cases, we don't certainly have a policy to wait for that to happen, but there have been some studies, especially a few weeks of lanreotide treatment could potentially give you a better surgical cure. So this man had a remission for several years, but came back at least 3-4 years ago with further recurrence. There's nothing on the scan I could see to offer him further operation. Everything was clear. There was nothing, and when you don't have a clear, definite target, I find it really difficult to go back in or difficult to offer them surgery, because I know the chance of a further cure is less and less. So in this situation, and especially with some of the recurrent tumors, we have started using, along with a collaborative work, along with the Cambridge and the Imperial, we've started using the methionine PET-CT scan to look for any evidence of activity of such tumors. In this case, we thought we could see some hotspots around the back of the clivus. It was not very clear-cut for me to really go into the surgery, but it's very forcing argument to try and redo the operation. And we do this for recurrent tumors which are not very clear, and also sometimes when you don't have a clear, definite tumor, microtumors on the MRI scan. Really Cushing's and even prolactinomas, it can be very sensitive as well. This is another lady I operated last year for a prolactinoma. This again, the gland appeared very heterogeneous. You don't have a target, but there was some abnormality in the right side, which is sort of N4. But again, unfortunately, there was no cure. Again, this patient will have PET methionine scan to look for the hotspot on the pituitary gland. You can do it without carbapenem to see whether the signal is switched off. And surgically, what are the considerations for me? Obviously the size and the extension to various cranial cavities, including the cavernous sinus extension, is a major surgical factor which we look into, and to decide whether you would want to try and cure the surgery, and whether you want to cure that patient or not depends on what sort of patient that it is. In an elderly patient where the main problem is the visual compromise, you may want to have a quality of life and you want to maybe be more conservative. But in a younger patient, if there's a good chance of cure, and also depending on the texture of the tumor, you probably would get a cure with a good surgical resection. Chiasmal compromise, a strong surgical indication. Anybody with progressive visual loss, you would offer them surgical approach. Growing tumors, another patient, sometimes can be a dilemma. If the patient been having ongoing monitoring for many years, but it's been growing slowly. So the question is, when do you do it? Is it when you think patient is very fit enough to have an operation, or in a later stage? So these are a few questions we think about. Obviously, medical factors, whether the patient is fit enough to have an operation. And also some patients are not able to decide for themselves, psychiatric illnesses or learning disabilities. These are things which will complicate the decision-making process. So it is good to have a combined teamwork. We have a very close relationship with the endocrine department, and to have a decision in our multidisciplinary meetings. And few other things which I just want to point out is the fertility issues. In certain cases where I think there will be a significant risk to the fertility, sperm banking and similar discussions should happen. And one of the things which I also would want to raise is the entity of the silent corticotrophic adenoma. Patients may not be having any symptoms of Cushing's syndrome or Cushing's disease, but when you do the operation, you find that it was a silent corticotrophic adenoma. They are slightly more pronounced in terms of the chance of a recurrence, and they have a higher risk of recurrence. So we tend to keep a close follow-up on them. And certainly all these patients will get workup, but we have made it a routine practice to do, just mainly for the navigation purposes, we tend to do MR angiogram for all the pituitaries, which usually not the practice in the past, but in the last 10 years, I've seen 3 cases with small aneurysm projecting into the tumor. And if you haven't recognized it, it can be a major concern, because then you get because one of the major complications we all worry about is the risk of intraoperative carotid damage. And certainly having missed an aneurysm, it will be a real danger during the operation. So whenever we plan this operation, we made it a routine practice to have an MRI scan and an MRI scan as well as CT scan. So this is the Imperial, endocrine toolkit, which we use for preoperative and postoperative management of such patients. If we go into that toolkit, you can see that the plan, as the speaker before elaborated, is fairly similar, and we have a protocol for how to have the steroid before and after the operation, starting with the hydrocortisone. But we have changed from the past, that we have now switched on to following the operation. When they go home, they usually go home prednisolone, which we find that more economical and more convenient for the patient. And this is a standard way we monitor and follow up this patient. Going back to the collaborative work, is just not the endocrine department we deal with, but also the ENT department. I know that in many units, neurosurgeons tend to operate by themselves, and they deal with the nasal aspect of the operation and also postoperative care of the nasal complication. But for me and for our department, I find that it is very useful to have a good collaborative work for the ENT department, because they are used to operating in that area, and also they can deal much better way with other nasal problems such as deviated nasal septum or pansinusitis, which you may have to look into before the operation. Because once you go in, sometimes when you find some infection in there, you have to abort the operation. So when you find pus, this is not an unusual situation. Sometimes when you go into operate without knowing about it, then that's a difficult situation. So often we get these patients reviewed if you find that there is evidence of sinusitis in the scans, and we get them cleared by our ENT colleagues. And the pituitary MTT is a process by which all these patients are reviewed before and after, and all these patients who are being monitored will come through this MTT, and decisions are made in a joint fashion. So I cannot emphasize that the relevance of such MTTs and the collaborative work with our colleagues. So the navigation, it's not a must and mandatory for a standard pituitary tumor. We didn't used to use it before, but often it's become much more easier to have a set protocol for all the endoscopic cases. That's what I found, that when you have a set parameters for all the endoscopic cases, there's no confusion among the junior staff or the radiologists or radiographers, that when you say that this is an endoscopic case, all these investigations are done. So you don't have to really specify. Previously, we only used to do it for extended endonasal approaches. Here we get a CT scan and an MRI scan with the pituitary with the contrast, even though they may have had a recent scan, and an MR angiogram. This is only for the reconstruction of the blood vessels. Often you find certain anatomical variations, such as this is the optic nerve here, fully exposed within the sphenoid sinus. This is a specialized cell called, it's one of the posterior ethmoid cells, which is very prominent, and often the optic nerve passes through it. If you not recognize it, if not careful about it, then one could easily damage this nerve. So similar bony landmarks one needs to know before going in. The septations within the sphenoid canal will give you some indication. Of course, you can see that one of the septum is going towards the cavernous sinus, and the other one is going towards the paracline or carotid on the left side. Very unlikely that you're going to see a very midline straight septum. And also the nasal septum, one have to really look into it. This is one of a large pituitary tumor operated almost 10 years ago now, I think. I can see the tumor, when they grow up, they often leave some grooves for the vessels to pass. The anterior cerebral artery complex is within the tumor, so it grows around it. All this grooving is by the carotids and the anterior cerebral artery vessels. So it will be useful to have a navigation system to see the extent, and also to look at the vessel anatomy, and also to, especially for recurrent tumors, the navigation is much useful. But for primary tumors, I don't tend to depend on navigation, because anatomical landmarks are the best. You always have to have a good idea about the midline. And here, the navigation system can be useful to really have a good three-dimensional orientation of the tumor and the pathology around it. You can rotate it, and you can have that kind of 3D concept when we operate. So when we operate big tumors, often the concern is how much tumor you have removed, and you don't know whether there is especially with the narrow waist in the diaphragm cellar, you may not know whether you've taken everything. Not every center will have intraoperative CT or MR scan. So this sort of three-dimensional orientation will be useful. I'll just go through one or two cases to give you some of the surgical tips, especially for the younger neurosurgeon. This is one of my colleagues, internationally renowned hematologist, with this big tumor. She was finding it difficult to see clearly, had visual disturbances. And you can see it's a standard pituitary tumor, and the chiasm is well stretched over the top of the tumor. It's a planic CT. You can see the sinus is fairly, the nasal septum is fairly straight, and there is almost a midline septum here. So the endoscopic approach is the right side. I just skip through all this, just a short video. You can see a spike in the nasal septum, but in the lower part. So this is not something which we need to do like a septoplasty, because your approach is around the middle turbinate, which you see there. So one may not need to really. That's the choana, which is one of the landmarks. As soon as you enter with the endoscope, this is the left side. Again, you see the inferior turbinate. And once you go down, you'll see the choana, which is the first landmark. And your intention is to identify the middle turbinate, and once you move it across, you'll be able to see the ostium of the sphenoid sinus. It is covered by a bit of mucosa there, but just about 1.5 to 2 centimeter, you will find the ostium right there. So the next intention is to expand this corridor we have. In this case, I wasn't planning to do a flap, because for standard pituitary tumor, there's no need to raise a flap, because raising the flap itself it's got its own mobility. So we don't do raise flap unless it's for a large tumor or an extended intranasal approach. So I won't show the technique of a nasal flap here. I'm just removing, the ENT surgeon is removing the part of the septum, which we're going to resect. But this part of the septum is kept as what we call the rescue flap, and the pedicle down here. So we kept that pedicle intact and secure, so that in case there is a need for a flap to cover for example, the patients get a leak, we can obviously use this flap in future. So the sphenoid ostium is expanded, the walls are expanded, and the cavity, the anterior wall of the sphenoid sinus is opened up fully, so that the larger the tumor, the bigger opening you need, because you need to see everything. Here, the main key concept is that your approach is tailored to the case you are operating. You don't need to do full wide exposure for all cases, but you need to do exposure as much as needed for depending on each case. Here, the cell is all opened up, the septation is all removed. You can see the remaining of the septation almost in the midline here. But the interesting thing you note here is that the carotids are fairly exposed. This is the paraclinoid carotid, which is exposed. Here also you can see the paraclinoid carotid. You can almost see the pulsation on that side. The bluish coloration is getting blanched there by the pulsation. There's only a thin shell of bone over here. And for such large tumors, it's generally my practice is to expose the back wall of the cella here. And this is all bone is all thinned out by the chronic pressure from this tumor for a long time. And once you reach the side near the cavernous sinus, you often get the bleeding from the cavernous sinus, which is not an issue at all. It can be easily controlled by squirting some flow seal or thrombin material inside it, or just push it a little bit, and that will be controlled. But the important thing is that you need to have a good view. You don't want to operate with the ongoing bleeding and ongoing obscuration of your vision. For an endoscopic operation, the main thing is the optics. Optics, you see everything. If you can see something, you can save it. Here, the bone is still out, but that bone was just covering the carotid, which is exposed here. Imagine if there was a big bone, with thick bone, you don't try to peel it off like that, because the side of the plate can then push on the carotid. So removing bony plate over the exposed carotid should be very careful. Here the incisions are made. This is an expanded cella, very thinned out dura as well. You can see the dura is thinned out by the pressure underneath it. The tumor is very soft. This is the standard way the pituitary tumors behave. There can be variation in many cases depending on what pathology you're treating. Sometimes you will be surprised to see that the tumor is very fibrous and firm, and you won't come out with your suction or other instruments. And in many cases of inflammatory diseases, which is another topic, often you find that the whole thing is fibrous. You won't be able to get anything out, and without really damaging some of the structures. Here, I did multiple cruciate incision so that I get a very wide exposure of the whole cella so that I can get the equilibrium clearance. So this is the bipolar, then shrinking all the dural leaves at the. So then the next step is to generally resect off and curate out the tumor. These are the curate. Now there is a sequence of curating. Just this mainly for the beginner, just to say that we go at the back first, the 6 o'clock position. Then you go on to the either side, the cavernous sinus, then only go for the front part. Because the reason is that when you have a significant supracellular extension, you find that if you clear out the front part, the arachnoid dome will come down into your cavity, and you often find it difficult to curate out the back, the posterior aspect, as well as the lateral aspects of the tumor. Here, the tumor is generally being curated out with gentle curettage. And this, how much force you use, especially in the lateral cavernous sinus, also around the arachnoid dome, because just above this tumor, it will be the arachnoid dome. So we are staying within the capsule of the tumor. There is a pseudocapsule which really pushes the arachnoid dome. So there will be 2 layers. One is the pseudocapsule, then there's an arachnoid layer, which will be coming down towards you. So the more you remove, the dome is going to descend down. This particular case, that hematology process, the dome was all coming down very nicely because the waist of the tumor was quite big. That's why it's coming down. But in cases where there is narrow neck, you find that you may have to go into that small pocket of the tumor to get it. And the normal pituitary, often you have to watch it or to define it during the preoperative workup to see where the normal gland is going to be. There will be some indication based on the stock deviation, but sometimes you may not be able to make it out. And you often see the tumor on the roof of the, see the pituitary gland on the roof of the tumor. Just keep it. So this tumor is being generally removed, and I'm also applying counter pressure onto the arachnoid dome so that I don't pull everything down. And I'll just skip forward a little bit. So here you can see the capsule is that is the arachnoid. It's very thinned out arachnoid. So any further pressure or any further push into that arachnoid will certainly cause a leak. The problem with the leak is that it's not something which we are not unfamiliar with. We often see it, and especially for extended advential approach, which Henry is going to talk about, that is a standard procedure. You go into the cranial cavity. But here, for standard pituitary tumor, you don't want to be in the cranial cavity if possible, because once you breach the dura, that's another level of operation. Then you have to deal with the leak, and you may have to bring the patient back to theater and maybe lumbar drain and nasociptor flap and fat and facial arthrograft. That's another level. So we don't want to have that if it is not indicated. Here, I just moving that tumor gently with counter pressure on the arachnoid. He said that's the outer capsule of the tumor. Here and there, that's the normal gland. Sometimes you can see as a separate, defined structure. Sometimes you may not see it. Just going to skip it. So this tumor is so this is the outer capsule of the tumor. So this is a radical resection, even though as a standard, sometimes we stay inside the pseudocapsule of the tumor. So then this cavity, because the arachnoid is coming down, I use some gel foam kind of material to keep it inside, and then some packing to keep that in position. So this is called Niso 40, which the ENT surgeons normally use. Post-op care, this is my standard instructions. Head up, just to keep some pressure away from the repair you made. And a few things asked for the recovery staff and the nursing staff to look for. Patients can have epistaxis, especially in the beginning stage, if you don't take care of the bleeders. Ask them to avoid blowing and sneezing. If they have to do it, they have to keep their mouth open. Of course, close monitoring by the endocrine team and the ENT team. And patients with lumbar drain after a leak, often we have to have instructions for the lumbar drain. generally tend to start low molecular weight heparin after 24 hours and post-operative MRI scan the day after. This is so this is the one of the cases. This is another case is a steatosarcoma. You can see the carotid is all encased, the tumor is, but it is a function tumor. So your intention is to get a good clearance. Again, this is a slightly different approach to standard pituitary tumor where you really want to be in the cavernous sinus. This is the pituitary gland over here. Pituitary tumor is all removed. This arachnoid dome coming into your vein. So I am on the left side of the tumor, inside the cavernous side. The carotid is passing through. The carotid siphon is right over here. So I'm clearing the tumor, but also your ability to cure this tumor depends on some luck as well. If you have a good tumor, which is soft and suckable, you can use instrument to remove it from the cavernous sinus. That's the tumor which is cleared from the cavernous sinus. So this is something we can have surgical surprises. This is a tumor which wasn't thought to be a pituitary tumor, but when I went in, it was a pituitary tumor, but it was planned for an extended procedure, thinking that it could be a cavernous sinus, thinking it's a craniopharyngioma. Here you can see I planned for an extended endonasal approach with a removal of all the tumor, but then it was an intracranial operation, which you'll see soon with Henry Stock. So this is, then I had to use a flap to cover it. Some of the pituitary tumors do possess some challenge and surgical surprises. And there are so many complications which we can spend a lot of time on, but one thing which I would just emphasize, everybody knows, all of us knows, is the carotid injury. So your clear view of your landmarks, proper midline assessment, and knowing about the carotid injury and thinking about that possibility all the time will help you to avoid it. That's the only thing I want to say at this point. And thank you for this opportunity, and Chandra for the introduction. Thanks very much.
Thanks, Ramesh. That was a wonderful exposition of some of your, the way you carry out your surgical procedures. I had one question about the radionuclide dye, which you said you use for PET-CT for functioning tumors. Is it FDG or something else?
Yeah, so it's a methionine. It's a methionine radionuclide material, and it is not completely being validated yet. So we're collecting cases to look at whether this is going to be useful in cases where you don't really have a definite target, because I know we all struggle with when you don't have a definite target, especially in redo procedures. You have pituitary gland on one side and you may have a different tissue on the other side. You don't know where the tumor is, and especially the case I showed you when you don't know whether there is tumor still in the clival bone. Sometimes it may be, so I've gone back in after using the scan, and my personal feeling is that the results are 50-50 yet, but we are still getting that data and being validated. So both FDG you can use, but this is the radionuclide material is methionine.
The second question has come in the question box about the use of CT angio versus MR angio, which you just talked about.
Yeah.
We actually do a CT angio because most patients come with MR.
Yeah.
So we do a CT for PNS and skull base anyway. So we do a CT angio at the same time.
Yeah. Yeah, good point. I think I used to do CT angiograms as a routine in the past, but the software for the our brain lab machine with the new versions, it's got much better with MR angiograms, because they do a very nice automatic reconstruction of the carotid system. So I find it easier to do it. So it's very automatic now.
Sorry about I've got a bad flu. And is it a non-contrast MR angio which you use?
Yes, it's a non-contrast. It's just depending on the flow within the carotid. But I think it generally, I mean, even though we operate, we don't depend, I personally don't depend on the navigation that much for the primary tumors. But still, I mentioned about this finding of some aneurysm, small aneurysm projecting into the tumors. And if you miss it, it can be a problem, because you'll be curating against that aneurysm, easily can get a rupture. And the recent 3 cases we had to treat the aneurysm first before we had to operate.
Obviously. Yeah. One other small question before I hand it over to Dr. King is that how do you ensure, or how do you really try hard enough to save the normal pituitary in most of these patients?
A few points, Chandra. First of all, I think it's important to really look for where where your pituitary gland is going to be. You look at the study, the MRI scans carefully, and the few direct and indirect signs of where the pituitary gland could be. That's one give you some idea. In certain cases, certainly in majority of cases, you can see that. You can see the stalk is deviating to one side or the other, and you can also see a sort of different kind of enhancing pituitary tissue apart from the tumor. But intraoperatively, often you see that the tumor consistency and the color and the texture is slightly different from the normal gland. And also the vasculature of the, I don't know the picture I showed you, the vasculature of the gland is slightly more sort of reticulated fashion on the pituitary wall. It may be thinned out and pushed up by the tumor, but it still retains that vasculature. And also the consistency is slightly different. So I try and preserve pituitary gland as much as possible without, obviously when you have big tumors, which you don't really see where it is and you want a radical cure, sometimes you may go a bit more radical than normally, then you might lose the pituitary gland, but it's possible sometimes to see it separately.
We also have a couple of questions in the Q&A just regarding your use of lumbar drains. Is that something you consider pre-operatively or only as a post-operative adjunct? When do you use it?
Yeah, thanks, Dr. King. I just put it that as you don't need to use the lumbar drain for standard pituitary cases because you don't, unless you get a major leak. If it's a small leak, you can get away without putting a lumbar drain or fat and fasciolata graft. It's a big leak. If you opened intracranially, like the case I showed, which I thought was a craniopharyngeal tumor, which I did an extended neuronas approach, or a giant pituitary tumor where you have a big deficit, big defect, and a large arachnoid gap, then obviously you would want to reduce the pressure at your repair level, and you put a lumbar drain. So it's not a standard practice, but in case of large leaks and large arachnoid defects, I use it. And I usually keep it for 3-4 days and then take it out after that. Because as you know, logical, there has been a significant or a substantial evidence to say that using lumbar drain can definitely reduce your leak rate.
Okay, thanks very much. We might move on to the final speaker, very well-known pituitary surgeon, Henry Schroeder. He's the professor and chairman at the Department of Neurosurgery at the University of Medicine in Greifswald in northern Germany. He's held many prestigious positions in German and international neurosurgery and is a real expert in the use of the endoscope in neurosurgery. So I'm very much looking forward to your talk. Welcome.
Yeah, hello. Thanks for the kind invitation. It's a great pleasure to be here. So my topic is the extended approach. Ramesh has shown nicely what is done with the standard pituitary approach. And this is an extension which is sometimes required. But of course, as he said, we try to make it simple, but sometimes we need to extend the approach. I was a consultant to Karl Storz, not anymore, because in Germany, Karl Storz cannot sell any equipment because they have not the CE certificate. They are still struggling with the medical device regulation, but hopefully they will be back in the end of this year, I hope. So when we talk about the stellar region, it's a very complex area. This is pituitary gland. It's surrounded by the cavernous sinus. You see it's carotids here. Ramesh has shown it nicely to you. We have the clivus, we have the nerves at the lateral wall of the cavernous sinus, and we have the orbit. And down we have the vidia nerve, which guides you to the junction between clivus, carotid, and petrous carotid. So all these structures are very important. When we go up, you have the suprasellar area where we have pituitary stalk, we have suprahypophyseal arteries, acom, chiasm. So it's a very complex area, so we have to be very careful. Traditionally, many of these lesions were approached by a transcranial approach, but if you have a lesion which is arising in the middle and pushing everything lateral, it makes sense to come from the middle, because otherwise you have always to cross these structures which were displaced by the tumor laterally. And that's why the results with the transcranial approaches were sometimes not so good, because we have always to dissect in between the windows between the nerves and vessels. So the best indication for an endoscopic endonasal approach are lesions which arise in the middle and displace everything laterally. The video nerve is a good landmark. Of course, nowadays we use navigation, which helps you also a great deal. But if you find the video nerve and you can follow it, and you realize that the nerve is not going medial to the carotid, but lateral to the carotid, then you know it's a guiding landmark. So if you drill below the video nerve, nothing can happen. But if you drill lateral to it or medial to it, it is a danger, because the artery is medial to the to the video nerve. It is important to know. So when you compare microscope and endoscope, we have the big advantage that we have the wide angle of view, and we have a perfect illumination and magnification. Some people still use the microscope and the speculum to dissect in this area, but for extended approaches, it's really hardly possible to be on a safe side and have a good radical resection. Come on, move. I have to stop it. Why is it not moving? Strange. Don't know. It's weekend in Germany. Maybe that's why. So this is the view with a microscope. You see here's the speculum, the margin of the speculum, and you see just the cellar floor, a little bit of the clivus, but not much. When we now remove the speculum and take a 0-degree endoscope, you see the difference. Because of the wide angle of view, you see the cellar, clival carotid, clinoidal carotid, lateral OCR, optic nerve. And because you have now the relation of all these structures together, it's very safe to operate. The microscope, you just see this a little bit, and you can turn a little bit the speculum, but you are very limited, and it's not advisable. Again, we turn back to the microscope. You see here's the margin of the speculum, and we want to remove tumor at the lateral wall, at the medial wall of the cavernous sinus. It's a blind curettage. You don't see it. When you use a 30-degree endoscope, you see nicely the wall, and you can really make sure to remove all the tumor. So there's no question in my mind that the endoscope is superior for it. Before you start with your surgery, of course, we have to look at the imaging. Ramesh has shown it. We always make a CT scan in adults and kids, not always. And we want to see what is the position of the septum, what is the size and the shape of the turbinates. We want to see where are the septi in the sphenoid sinus. The septi in the sphenoid sinus are the best landmark and shows you very accurate what is the distance to the carotids. It's much better than navigation. Navigation is not as accurate, so the anatomical landmarks are always better, and you should look at these. Then, of course, we do an MRI because you want to see what is the relation of the lesion to the carotid, where's the pituitary stalk, where's the chiasm, what is the intercarotid distance. So, of course, MRI is also required. Positioning, we always position the patient with the back 30 degrees up, and even though you do it, sometimes the pressure in the cavernous sinus is amazingly high. It's interesting. Sometimes if you open it, sometimes it's very relaxed, but if you have obese people, sometimes it can have a very high pressure, and sometimes you're concerned it is an artery which is bleeding. So that's why, especially in obese people, you have to relax everything, bring the body up, turn the head to the side of the surgeon and tilt it to the other side, that you have a very convenient way to look into the nostrils. You prepare the mucosa with 1/1000 epinephrine. The navigation is used in the extended approaches. But if I have a very well pneumatized sphenoid sinus and I have a supracellular lesion like a craniopharyngioma, I don't use navigation because I think it's not of great help. But in some cases, it is. So instrumentation is very simple. You don't need much. But what I think, what is advisable is that you bend your suction as you want to have it. So I have a suction which goes straight up and one goes a little bit down and back. So for my hands, it's ideal to go in each corner. All what is available commercially, I don't like it so much. That's why I made this bending at the tip by myself with a Fukushima suction. And then what is very nice to have is a monopolar suction device, because in the initial phase, there's not much space. You go in with your endoscope, you displace the turbinates, and then you have a suction and a coagulation. That also is of great help, in my opinion. HD camera, of course, it's required at least. Some people prefer 4K. I personally stay with the old HD camera because I think the color fidelity is better. When I saw all the 4K cameras, I think the red is not natural. That is my personal opinion. Resolution, of course, of 4K is also good, but this is an HD camera. You see how nicely you see all the small vessels. You know, the superior hypophyseal artery is very important to preserve, to have a good visual outcome. And this anatomy is very variable. Sometimes you have 1, 2, 3, 4, 5 small vessels. Sometimes you have one major one. And if you have a major one, you should not damage it. Otherwise, you have really a problem. And above the chiasm, you see here ACOM, A1, A2, A2. And when you go very close with your endoscope, it's interesting how high is the resolution. You see even erythrocytes running through the levels, through the vessels. So the HD camera and good rod lens optic is still the best image quality you can get. So chip on the tip is good, but the quality of the image is still the best if you have a rod lens and then the good camera. So in extended approaches, we use a binostril approach. One surgeon is holding the scope and irrigation, and the other surgeon has instrument and suction. We work closely together with our ENT. You see, this is my former ENT guy. You see, he's not happy when he sees a neurosurgeon operating things through the nose. He likes it that way better, but I think it's good that you work together because you can learn a lot from the ENT how to preserve the mucosa. For us, the paranasal sinuses and the mucosa are just in the way to our target, but they treat it carefully, and you know the post-operative quality of life, the nasal quality of life should be high. If you have always crusting, dry nose, stinky nose, that can be a disaster for the patient. That's why we have to treat the mucosa very carefully, and then we can have good outcomes. Bimanual dissection is this what I like to do when I have a tumor which is intra-arachnoid. So I grasp the lesion, and with the other hand, I dissect the arachnoid away. I don't like the videos where you see a big grasping force that's coming and pulling simply out of it. So you have to dissect the structures because sometimes they are sticky and it can be a problem. Pituitary gland. When you look at the pituitary gland, you see that the gland is swimming in a lagoon of venous blood. So all around the gland is venous channels. And some people say you can make a pituitary transposition. And the original version of the pituitary transposition, which was suggested by the Pittsburgh group, is certainly not good. Because when you take the gland out of these venous lagoons, all the venous outflow is stopped. And you see here, this is superior hypophyseal arteries. In this case, are many small vessels. So it's very variable, the anatomy. So I did it in one case who presented with an Addison crisis. So the pituitary gland was not working, was a craniopharyngioma with a retrocellular extension. So I dissected the gland as the Pittsburgh group has advised at that time, went around. Then at the end of the dissection, I brought it back and it looked like a black, dead, swollen thing. And then I just cut it. And you see, this looks not healthy. So I think this type of pituitary transposition is not advisable. What you can do to make a hemitransposition, you dissect between the gland and the medial wall of the cavernous sinus on one side. But if you take it out, it will not survive. So supracellular anatomy I have already shown you. You see the chiasm, pituitary stalk here, and here's the superior hypophyseal arteries. And here very close is the ophthalmic. So you have to be very careful when you dissect and cut the dura. You have to be careful because here is this is already here. This is the ophthalmic. Be very careful that you do not damage it. Here you see this is a variation. This was one case where I went for surgery with an eyebrow approach for this aneurysm. And then when we looked in, you see the artery is coming from the aneurysm. So you have no chance to clip it, and I left it. I just left it because when you close this vessel and you have this anomaly, that is the supply of the whole chiasm and infundibulum from one side, and you damage this artery, of course the patient will be blind or at least severely disabled with visual field and acuity. So this has to be preserved. And sometimes you see these anomalies. Skull base reconstruction is very important. So when you start with your case, you have to think about what want you do, what is the approach, and what is the defect I create. And depending on this, you have to plan your reconstruction from the beginning. You should not go in and then say, oops, what should I do now to close it? So Ramesh has shown nicely, if you have no CSF flow, you can just leave it open. Some people like me put gel foam that it keeps a little bit dry, but you can also take the bone back from the floor and bring it in. You can take a resorbable plate. This is polydioxanone, which the craniofacial surgeon used for orbital floor fractures. If I have a minor CSF flow, I just take a little bit Duragene, fibrin glue. Sometimes I reconstruct the bony floor. But if I have a major CSF leak, for example, in craniopharyngiomas, then I create a nasoseptal flap. Sometimes I use a lumbar drain. It is always done when I have a big hole in the third ventricle, because then these pulsations go directly to a reconstruction, and I think it's better. The group in Napoli, they say, no, it's not needed. We just place the patient up 45 degrees all the time, maybe. But if the third ventricle is open, I usually make a lumbar drain. If it's a clival tumor or it's a meningioma and the arachnoid is preserved, then I don't do it. But for cranius with opening of third ventricle, maybe it's better. I don't know exactly. So nasoseptal flap, if you raise it according to the defect you create. If you have a big effect, you have to take all what you can. So you can go to the mucocutaneous junction, go up, make it very bright, white here. But in the olfactory area, you should stay at least 1 centimeter down from the skull base. It's very important that you look at it. Sometimes you see people, they cut this way, and then, of course, you lose your affection. So you go down, leave this olfactory mucosa, and then you create this flap. Important is keep the pedicle intact. Don't go too far down. And then what we have done in the last 10 years is that we create a reverse flap. It's the idea from Rick Corral. That means you take the mucosa on the other side and you cut it reverse. And then when you have to resect it, the bony septum in the back, you can flip it. You can flip it over the area where you have taken the nasoseptal flap. So this denuded area is then covered with mucosa, and the reepithelialization is much faster. It's a big, big difference. You see. This is strange, huh? Strange program here. And then usually you see good enhancement of the flap after your surgery. This is the fat we put with the fat suppression MRI, and this is always covered. So nasoseptal flap, very important. You can decrease the post-op CSF leak rate. Some people are optimistic. They say under 5. I would say between 5 and 10% if you consider all these clival chordomas, which have a high risk of CSF leakage and also huge openings at the anterior skull base. So what approaches we do? The transcellular, transtuberculum transplanum, transclival, transcavernous, transpterygoid, and transcribriform. This is what we can do, and Schwarz made a nice overview. What area you can reach from these different approaches, and you can reach the anterior, you can reach the skull base from the frontal sinuses down to the odontal process. Everything you can reach. But just in the midline, that is very important to consider it. There are limitations, of course. It's only midline scalps. All what is lateral you cannot see, and then there's many indications, in my opinion, where you get that better go from a transcranial approach, especially in the anterior skull base. It's a big discussion about the meningiomas, you know. Vessel encasement, of course, you can better deal when you come transcranially, because if there's a rupture, it's more easy to deal with it. No crossing of the nerves. It's a good rule from the Pittsburgh group. Tumor consistency is, of course, important. If you have a suckable tumor like chordomas and chondrosarcomas, it's easy from the nose. If it's more fibrous, like meningiomas, becomes difficult. Anatomical variations, you have to consider. Kissing carotids can be a contraindication, and age of patients. If the patient is too young, it can be a problem, but it's an individual decision. We did surgery for a child 2.5-year-old with a chordoma, was a clival chordoma, And we thought it might be a little bit narrow, but it worked very well. Even we changed from 2.7 millimeter optics to 4 millimeters because there was enough space. So you have to look at the MRI and then you make the decision. So examples, when we use this extended approach, this was an unusual tumor. It looks like an Indian tumor in Germany. It's very unusual. You see on the right eye, almost blind, left, also very bad vision. And you see a lesion, but usually we don't see in Germany. It's a huge thing with compressing of the midbrain. So that's where you had a hemiparesis. And of course, in this case, what would you do? Some people would say, I come transcranially. But we always start, even in the huge tumors, endonasally. And then we see how much we can get out. And Ramesh pointed out, it's very important. If you see that you leave a significant amount of tumor behind, you should go in immediately with a transcranial approach. Because if you don't get it out and you leave it, you will get a hemorrhage. And that occurred in my series 3 times, where I had a tumor in the third ventricle, which did not come down. And then I stopped it, and in the night he deteriorated, had a hemorrhage and hydrocephalus, became symptomatic because of occlusive hydrocephalus. And then we went in with the lotoscope and resected the tumor from the third ventricle. So if you see there is a significant amount, don't wait, because this might cause problems in the night. You see here also she has hydrocephalus, she has compression of the midbrain severe. And then we made an extended approach. We raised the nasoseptal flap. Then first we just open the cellar thing. You see optic nerve on the left, optic nerve on the right. Tumor is soft, that was good. So we take a lot of specimens for histology. Bleeding tumor, you see here is some normal gland, yellow. And then we open the dura, and you see this is the optic nerve on the right side. And you see the tumor nodule. It's really squeezing the optic nerve and pressing it against the optic nerve, the A1, pressing the optic nerve against A1. So the tumor is resected. And here you see, this is the right optic nerve, and you see the pressure of the tumor of the nerve against A1, the pulsation almost cut completely the right optic nerve. And that's why she has this bad vision on the right eye. And then we dissect the tumor. You see, we change now to 30-degree optics to look a little bit more up, and later on we change to 45. This is the diaphragma. So don't take the diaphragma away, just peel it off, because above the diaphragma, there are probably vessels which supply the chiasm. So no need to cut it off, just peel it off and take just the tumor. See here, curved ENT instruments, 30-degree endoscope, and later on we switch to 45 because the tumor was not coming down. A little bit bloody, but it is in these lesions. Sometimes you see this 45-degree, we're looking up to the midbrain. And here you see this oculomotor nerve on the left side. And this is a resection, what we get. And then you post-op MRI. This is our fat filling the dead space. This is our nasoseptal flap. You see we left a little bit tumor behind the perforators of P1 and PCOM. This was behind the perforators. We just left it, but this is surely not a problem for her. And this is a follow-up MRI. Looks quite good. Another indication, a good indication for extended approaches is chondrosarcomas. This was a 60-year-old male presented with abducens palsy, had a transcranial attempt, but they could not do much because the nerves of the cavernous sinus were all on this outside. You see, this is a tumor displacing the gland to the left, infiltration of the cavernous sinus, and then it goes all around the carotid. So here's the petrous carotid, tumor is lateral to the petrous carotid. So this is an ideal indication for an endoscopic endonasal, because you come here to this area and you can get the tumor very nicely. So it's a transcellular, transcavernous, transpterygoid approach. Navigation is used to localize the carotid. So this is the cellar floor, is drilled. Now we go lateral, unroofing of the clival carotid, unroofing of the cavernous sinus. And then we drill the petrous bone. So we open the maxillary sinus, looking for the video nerve, and then we follow the video nerve. You see here, this is the video nerve running here down. This is a video nerve, and you just follow it and have a good anatomical landmark for the foramen lacerum. So we open the sella dura. You see the tumor is like gelée, like jam. You can easily remove it. Now we come to the cavernous sinus, and now we switch to a 45-degree endoscope. And you see, we see the lateral wall of the cavernous sinus. This is the oculomotor nerve in the lateral wall of the cavernous sinus. This is a clival carotid, cavernous carotid, and then clival carotid. This is a pituitary gland. And you can nicely resect the tumor. This is now the petrous carotid, and we can go with a curved suction lateral to the petrous carotid. And because the tumor is suckable, you can get a very nice resection. Of course, you want to drill as much of the bone around because there is a tumor inside. But here, of course, laterally, you just suck it. You see here again, video nerve, follow it. You see the clival carotid, and here's the petrous carotid. So it guides you to the junction between clival and petrous carotid. Again, we go in from the nose. You see the maxillary sinus, and here's the video nerve, and you go down. This is a clinoidal carotid, cavernous carotid, clival carotid, and down here you see the petrous carotid. And the post-op MRI shows that we got almost everything except this small nodule, which is intradural. So we are not chasing for this small nodule here to prevent CSF leakage. And you see after 2 years, it's the same size. So we never sent chondrosarcoma, the benign ones, for radiation. Of course, if it's an aggressive dedifferentiated, then it's different. But in the normal chondrosarcomas, we don't add radiation. So it's different to chordomas, where we always add proton beam. And the patient died 4 years after lung cancer without any problem with this residual. Chordomas are a little bit different, more aggressive. One example, this was a lady, she had a history of venous thrombosis. She was under Makuma anticoagulation, and suddenly she had headache and certain nerve palsy. And she came to our emergency department. You see hemorrhage, but not hemorrhage to the brainstem. Otherwise, she would be in coma. It seems to hemorrhage into something. So we're waiting, asking for MRI. And during the waiting period, she developed an incomplete cavernous sinus syndrome and a progressive hemiparesis. Then we have the MRI. You see this lesion here extending to the CP angle on the right side. And here you see already some changes in the peduncle of the brain, which explains the hemiparesis. And when you look, how could we deal it? Before, it was usually this combined approach, but you see all the nerves are in front of you. And I have seen very good surgeons in Germany operating chordomas via this approach, but sometimes one nerve or the other could not be preserved from this approach. And you see here, obviously, is the origin in the clivus. So it should be a clival chordoma. It's a midline tumor. Chondrosarcomas are usually off the midline. So when we want to resect it from endonasal approach, you see we have to go up here because there is a clot. You see here is the edema in the brainstem. So when we want to go there, we have to remove these dorsum celli and the posterior clinoids, and you can elevate the gland in the dura and you can get there. If you leave this bone, you will not get it. So the approach should be a transclival approach. Transclival approach. What is the problem with this thing? Ramesh, what is the problem? We're not forward. Strange, huh?
Yeah, it's not going forward.
Why? It's always going forward. Strange. Can you see it still?
So you have stopped sharing now, so you have to reshare now.
Okay. It's strange, huh? This never happened.
The network is a bit low, maybe.
Huh?
Maybe the Wi-Fi may be a bit weak.
No, Wi-Fi is good.
Okay,
Can
we
you
see
see?
now. Yeah, we see now.
Video is running?
No.
It's not running?
It's running now, but yeah, I think wait a second, it'll probably should run. Yeah, a bit jerky, but it's working now.
Should I stop it again and start from the beginning?
Sometimes it corrects by itself. Like we can see the posterior clinoid being taken out in that video.
Is now the quality good?
It's running. It's okay.
It's okay. So you see that it's not very well pneumatized. That's why we use navigation. So we start to drill the bone, unroofing of the clavicle carotid on both sides to get more space. And then we take now the floor of the cellar. See, all is infiltrated. It's not normal. And then we took the posterior clinoids. There are sometimes dural bands and venous channels. So there's some bleeding, which can be solved with flow seal. Flow seal is a really magic when you have venous hemorrhage. And this is our approach. You see, this is a cellar dura. And here's a clavicle dura. And we cut the clavicle dura in the midline. And then we take biopsies. And you see it's a soft tumor. It's easy to take it. And there's a clot. Now you see we switch to a 45-degree endoscope. And with a curved section, we can get this clot out, which is far up. You see, this is the basilar apex. You see P1, superior cerebellar, oculomotor nerve on the left. And this is the oculomotor nerve on the right. It's squeezed by the tumor. And then the additional hemorrhage causes oculomotor palsy, which became apparent suddenly. So then we dissect the capsule and the small perforators from the brainstem by manual dissection. And then there is only the remaining part, which is in the CP angle on the right side. And with curved suction, again, we take it. So this is the trochlear nerve at the tent. This is the trigeminal nerve. And this is our resection from this small window. And you see, this is our nasoseptal flap, some fat and glue for closure. And this is a post-op MRI, shows no obvious residual. See, this was a compression of the peduncle causing the problem. And after 2 days, oculomotor palsy recovered, and after 5 days, hemiparesis. And this after 12 months. So another very good indication for an extended approach are craniopharyngiomas. This, in my opinion, has changed a lot compared what we had before with transcranial approaches. And transcranial approaches, we frequently had additional visual problems, especially in such cases. You see here, this is a chiasm. You see the skull, so it's a prefixed chiasm, which is frequently the case in craniopharyngioma. What was the approach at that time? Like Yashagil said, pterional approach. And you see, this is all chiasm. You don't see anything from the tumor. It's chiasm, carotid. So only in the retrocarotid window, you see here is a lesion. But it's very difficult to go in. You go here, dissect, open it, then you collapse it, then you dissect in between here, create a new window. But this has in some cases caused to a new visual deficit. The anonasal approach gives the advantage. You see the gland, you open the diaphragma, and you always find the stalk very early. And you also see where are the superior hypophyseal arteries. So it gives you much better orientation and ability to dissect. So this is a very helpful classification from Kassam. So the pre-infundibular tumors are the best. You have the best chance to preserve the stalk functionally. When they are in the stalk, so transinfundibular or intrainfundibular, it's more difficult. And then the retroinfundibular tumors are also more difficult to dissect. So this is a pre-infundibular type. This is strange. This is very strange. I'm so sorry. This never happens. Gesundheit. Why this happens here? I open it again. Maybe this is a problem. I don't know. I had never the problem.
I feel, Henry, I think maybe the computer is maybe a bit taking a lot of strain, or maybe running a bit slow or something.
No,
laptop, maybe.
No, but it would be slow, but it's not moving at all when I go and forward it. It is very unusual. It is very unusual. So now I go again. So I hope you see it now.
Yeah, we can.
So this is what we see when we open the dura. This is a gland, and we see tumor, but then we can elevate the tumor and we find the stalk. We just follow the diaphragma celli and you find it. So one guy with a visual field problem. On the right eye, you see visual acuity is poor and hemianopsia, but endocrinologically completely intact. So when you look at the images, you just see a cystic lesion, but it's very difficult to say where's the stalk. You cannot see it, cannot say. So what we do is we open the bony bone, the zellar floor is removed. Then we open the optic canals a little bit and make these transplano tuberculum approach. The arachnoid is open, and then we follow it and make it by manual dissection if possible. So I elevate the tumor now, and now I see the stalk is running here. And you see all the small vessels are all supplying the infundibulum. These are not tumor vessels. So by manual dissection, traction, counter-traction, rescuing the arachnoid to dissect this away, then sharp dissection as required. Stalk is here, fundibulum comes here, this is a chiasm. And then we dissect the thing circumferentially, not simply pulling. You see another vessel here. This is attached to the tumor, but it's not a tumor vessel. It's just supplying the infundibulum. So that's why I try to preserve all these small vessels and pull it from the tumor away. And then if it's completely detached, then we take the tumor out. Combination of traction, counter-traction, and sharp dissection technique. See, this is a lesion, and this is after surgery. You see the chiasm, this is a pituitary stalk, it's a carotid, it's a PCOM, all preserved. And you see 1 day post-op already improvement of visual field. So it's a vascular problem, perfusion problem. And he did not gain weight. And endocrinologically, he's completely intact. And this is after 4 years, you see no recurrent so far. And the good thing is he does not need any substitution. So the preinfundibular types are very good. It's more difficult the transinfundibular tumors, because when you open, you see the stalk is enlarged because the tumor is inside. And then, of course, we have to cut somewhere to open it. One example, 29-year-old male, history of headache, fatigue, decrease in performance. So the girlfriend was not happy with him, sent him to the doctor. They found a partial pituitary insufficiency, and you see a huge tumor filling the third ventricle. And when you look to the lateral side, you see a huge tumor. All third ventricle is filled with tumor. Then when we discussed it, my guy said, oh, we have to make transcallosal to get in. But the longitudinal axis is in this direction. And what is very important when you consider endoscopic endonasal surgery for these huge tumors, you have to look at the distance between the chiasm and the gland. And in this case, it is really a big distance. Usually you have only a few millimeters, sometimes only 1 or 2, then the approach is difficult. But if you look here, chiasm, gland, there's almost 1 centimeter space. You see prefix chiasm, this is skull base, this is chiasm. So endonasal should be an option. So that's why we said, let's go. We make endonasal. So we open it, you see the pituitary gland, optic nerve left, right. This all is stalk, very dilated, the stalk. So we open the arachnoid, you see the vessels supplying chiasm, so it should preserve as much as you can. So we open it, and then we have to find the right plane. This is not tumor capsule, this is all normal infundibulum. Ultrasonic aspiration in this case was very helpful because the tumor was not so much calcified. And then again, you see, this is the normal infundibulum. And here we switch to 45 degree and we dissect by manually. You see, it's very adherent, but I'm always in the gliotic yellow plane. I never saw white hypothalamus. If you see white hypothalamus, I would stop because this caused a problem. But here you see we have a good gliotic plane all around, and with traction, counter-traction, we were able to dissect it. It's very important. As I said, you should circumferentially dissect the lesion. If you just pull, it can be a disaster because it might adhere into very important structures. And here my forceps was not reaching up, so I had to bend my suction a little bit more. And then I could dissect around the tumor. And only then, after the complete dissection, you bring the lesion out. This is a view after it. This is a roof of the third ventricle. This is the aqueduct and foramen of Monroe. And of course, you have a huge leakage here. So you need to put fat in the dural defect, fibrin glue, and then the nasal septal flap. This is MRI 10 days after surgery. You see a nice nasal septal flap. No tumor remnant. It's now 9 years after surgery. No tumor recurrence. But he needs full supply of the pituitary hormones, including minurine, because he has DI. But the good thing is he has no obesity. This is a major risk in this lesion, and he has a normal visual field and normal visual acuity. So I think it's a nice result for this. And the girlfriend was happy with testosterone substitution. So do we always try to make a radical resection? You know, this is an old lady, 76-year-old, visual field deficit, but no problems with the hormones. You see cystic lesion. So what we do in this case, we go in, you see this is a cyst compressing the optic apparatus. We open it, chiasm free now, and then we look to the stalk. All is involved in the tumor. So when you resect the stalk, she will have DI for sure, and pituitary problems. So what we do in this case, we just send her for radiation. We make a fractionated radiation, 54 grays, 30 fraction, 1.8 gray. And you see, she is now now I think it's already 4 or 5 years. And so far, she's not requiring any replacement. So I think for older patients, it is an option to just decompress the cyst, leave the tumor and radiate. The radiation has really a very good result. So when we compare our series of transcranial approaches with endonasal, we clearly found that the result is much better regarding visual outcome, lower rate of diabetes insipidus, lower rate of obesity, but of course higher risk of CSF leakage. So I think in craniopharyngiomas, for me, it's pretty clear. In most cases, the endonasal approach is a better one. Of course, we have large lateral extensions, then sometimes you make a transcranial approach. What is about the melangiomas? You know, there's a lot of controversy. Is it endonasal? Is it transcranial? In my opinion, most of the tumors are done transcranially, especially olfactory groove, because I want to preserve olfaction. Many of these patients have still olfaction when you make an endonasal approach. Usually it's gone. Some people say, no, I can do just a unilateral approach, but the tumor is crossing the midline, so the radicality will be not good. And this is ideal for an eyebrow approach. I think this is much better than endonasal. But there are some indications, of course, especially tuberculum selling melangiomas. When you have a very steep tuberculum, small midline tumor, this is a good alternative. Here you can come easily endonasally and take it out. So we open the cella floor, we make a tuberculum transplanum, optic nerve canals are here. So first step is coagulation of the superior intercavernous sinus. Then we open the dura, make a V-shaped opening. The good thing is when you come from here, you truly completely devascularize the tumor already. So when you open the dura, you find a lesion which is really dead. You see, it's not perfused and it makes it easy. It's a small one. The arachnoid is well preserved and then it's easy to dissect. But you have to be careful of these branches, superior hypophyseal arteries. They can go in between the lobules of the tumor. And then it's a problem, especially if the arachnoid plane is not preserved, then it might be more difficult. That's why in most cases, I still do transcranial and some smaller tumors midline. And as you see, we can cut the infiltrated dura close to the carotid. Can dissect it, have to be careful with the ophthalmic to look where it is, and then we can resect all this infiltrated stuff. So for some of these tumors, endonasal can be done, but in the majority, I still prefer endoscopic endonasal. You see here, we just put gel foam and then with the nasoseptal flap. So no lumbar drain in these cases, of course. See a good flap. And this is now 1 year after surgery, is doing fine. And the last case I want to show you is time, or is a little bit time. This was a 42-year-old male. He had visual problems. He had a transcranial surgery, but still deteriorating. And it shows a lesion, which is here in the superior orbital fissure and cavernous sinus. Seems to be very well delineated. They came from lateral, could not do much. The histology was just fibrous tissue. And when you look here, this is the optic canal. This is the lesion, and the tumor goes into the optic canal a little bit, causing the problem. And you see here, down here, what is this? This is V2. So here we have a distance between the carotid and V2. This is a wide window, which can be easily used. So we advised him that we make an endoscopic operation. We can decompress the optic canal better than they did transcranially. And if we are lucky, we can remove the tumor, or at least we take a biopsy. So we make an arthrostomy. This is a maxillary sinus. This is the apex of the orbit. This is the lateral wall of the sphenoid sinus. So we open the lateral wall of the sphenoid sinus, remove the bone, and then we cut the dura longitudinally, because this is, of course, where V2 should go. And you see, we were very lucky because the tumor had a very nice plane, and with bimanual technique, traction, counter traction, we could dissect the lesion completely around. So this was a meningioma, which was not the typical infiltrating type, but it was developing in between two leaflets of the cavernous sinus dura. And you see, this is branches of the V2 here. And we looked, inspected, no tumor recurrent, no tumor remnant. This is the amount of our opening. This is V2, and here's the optic canal. And you see visual field is okay. He had no oculomotor problems after surgery. And now he's almost, I think it's almost 10 years or more. It's more than 10 years. Visual acuity is 100% and no recurrence. So this is a rare tumor in this area. Usually you have this diffuse infiltrating type, then of course it's not working. But if you see this very delineated lesion, then you can do it. This is our series of endonasal skull base approaches. Of course, most of them are pituitary adenomas, but also craniopharyngiomas. It's very nice. Chordomas, no question. Chondrosarcomas, sometimes arachnoid cyst, rectus cleft cyst. Meningioma, not so many. Complications, of course, CSF leakage. We had 2 cases with carotid artery injury. One was a disaster, was very difficult to deal with it. Ramesh notes already. He's still good. We did not touch the aneurysm. It's still small in there. And meningitis is rare, and nasal hemorrhage can happen even after normal pituitary surgery. So you have to coagulate the vessels where the posterior nasal arteries comes from the sphenopalatine if you make a standard approach without the flap. And the conclusion is that the endoscopic nasal approach is ideal for many lesions, pituitary, chordomas, chondrosarcomas, extradural tumors in general. And then all the best indication is the craniopharyngioma, which is a midline. Meningiomas, some can be done, but mostly I do it transcranially. Then I want to invite you to the World Congress of Neuroendoscopy in Singapore, and I hope everybody will join us, where we discuss all the topics of endoscopy, including ventricles, skull base, pediatric, and spine. Thank you for your attention.
Thank you, Henry. That was a masterclass, a great talk, and a series of amazing cases. Can I just ask, on craniopharyngioma, if you've got a gross total resection like those cases you showed, you wouldn't irradiate those patients?
No.
With a small residual, what would you do?
In the small residual, usually I watch, but in some, I know, for example, we do sometimes cystic ones, endoscopic transventricular. So we open the cyst, resect as much, and an older patient, I always send immediately to radiation because I know it will come back. If I'm not sure, is it really an active tumor, which I leave behind, then we watch with MRI. And if we see it starts to grow, then we irradiate. So we have, I think we have 2 cases where I thought it's a gross total resection. And after 2 years, you see a small residual coming, small recurrence coming. and then I send for radiation. So usually we watch, but in cases where the concept from the beginning is partial resection, then I make immediately radiation. But if I don't see any remnant, I don't radiate. That's only in chordomas, because in chordomas, you know, even if you take everything, you know that around in the sleeves of the nerves and in the bone, there is some residual. Then we send usually for proton beam.
I have a question.
Ramesh has a question.
Yeah.
Yeah. Yeah.
Can I ask
Dr.
you?
Yeah, may I have a question to Dr. Ramesh? Dr. Schroeder, thank you very much for this beautiful and didactic presentation. Just one question for you, and then a question for both of you, for Ramesh and Dr. Ramesh, and for you. You mentioned all the time that skull-based midline tumor. So my question is, how lateral can you go from, you know, the mediolateral aspect, and also how low can you go in terms, if you are still on midline, how low can you go? What is the limit? This is the question number one. And the other question, you know, we haven't speak in this both presentation about the role of radiation in terms of adjuvant or in terms of upfront, you know, especially for the issue of recurrent functioning pituitary adenoma, when you can really identify the residual in the cavernous sinus, of course, craniopharyngioma, which is very sensitive to radiation. What is your philosophy, both, about that?
Okay, the caudal limit of anonasal is usually the odontoid. So you can get the odontoid from C2, you can drill. We had chordomas which go to the body of C2, I could not get from the anonasal, so I have to add transoral in the same procedure. So we just went transoral and took the caudal part. So it depends from the anatomy. It's a little bit individual. When you see the hard palate, you can draw a line from the bony nose to the hard palate, and then you see how far you can get. Of course, you can also use a 45-degree endoscope. You can look a little bit more down, and we have also a curved drill. The ENT have nice drills, 15. I think even they have even a 70-degree drill. So sometimes you can go around the corner. But if it's too far down, you have to add a transoral approach. Laterally, it depends. Of course, if the tumor goes over the carotids, sometimes you can pull it in. So if you have a tuberculum meningioma, it makes a little bit bulging over the carotid, you still can get it, because usually it's not attached there. Usually it's attached at the bone medially to it. But if you go in and you see you cannot get it out easily, you have to stop. I had a recurrent case of a girl from Tunisia, and I dissected, and then there was no plane because it was a recurrence. And of course, you should leave this part which is over the carotid or lateral to it, because it's adherent there. And regarding the radiation of hormone active tumors, if I do my surgery and I go into the cavernous sinus, try to resect, but cannot get everything because it goes in between the tubercula, then of course we stop. Our endocrinologists usually don't advise for radiation. They try always with medication, because they say if you irradiate, there is a higher chance that the normal gland will, after 3 to 5 years, stop working, and you have to supply all the hormones. That's why usually in acromegaly, they give medical treatment. And only if this is not working well, or if we have a patient, he cannot afford it because he comes from foreign country, then we make this radiation therapy.
Yeah, I'm not talking about whole pituitary gland irradiation. I'm talking about radiosurgery for residual functioning adenomas in the cavernous sinus.
Yes, this is an option, but usually our endocrinologists first try to make the medical treatment. And if this is not working, they will consider radiation.
I think Ramesh has a question.
Yeah, thank you. I just wanted to touch upon the question you asked Dr. King about when do you radiate for remnant if you have left a small residue of craniopharyngioma, and you know that there is a small residue intraoperatively, when to radiate. In certain circumstances, I do go upfront radiation, especially if it is a papillary craniopharyngioma, when I know that the risk of the recurrence is quite high when compared to the adenomatous types. So that's one point I want to make. I just have a question, and I want to hear from Henry about if you do a chordoma and you've taken out the bony chordoma and you see that the dura is attached, it's not completely infiltrated, it hasn't gone through and through. Would you resect the dura? Because that's the next stage. What is your view whether to resect or not to resect when you do a clival chordoma?
No, when the dura is intact, I just take the outer layer. I take the outer layer away, but I would not take the whole dura. So we had this young child, 2.5 years. I did not resect all the dura because it was a huge defect. And then in this child, this crying and pressing and squeezing, it's a high risk that you get a lot of problem. And we did it. It was that, I think it's also 8 years ago or so. And there's no recurrence so far. Yeah. But we add, of course, proton radiation.
Yeah, of course.
But if the tumor is infiltrating through the dura, then I try to cut all infiltrate. I don't just take the tumor, but then I cut around. But if there's no leakage, I would not add, I would not open it.
Yeah. Okay, thank you.
So 2 anonymous questions on prolactinomas with visual deficit. Would you consider medical or direct surgical treatment? And secondly, I think, how do you deliver flow seal?
So always when it's prolactinoma, we start with medication. And we had patients, huge tumors. It's amazing how fast they shrink. Yeah. So, and even it makes the surgery much easier when you have these huge tumors and it shrinks down and you have a small residual, then you can make later the surgery. But in most cases, you don't need because it's responding very well. So no surgery initially. Even if the vision is bad, it will improve very, very, very rapidly with medication. And then there's flow seal.
Yeah, I think the newer valves of flow seal come with a delivery system. So it's not really otherwise you can use anything from LP needle to various long ven flons or whatever you call them. Yeah. About radiation, I had one point. I don't know how you would respond to that. One of my main criteria when I see a small remnant or I feel that I have left a small remnant, though it is not very clearly seen on post-op MRI, is also the age of the patient. Yeah. I mean, below 5 years, I do not advise radiation at all. Yeah.
I completely agree. In children, we try to postpone the radiation as much as we can. Even would consider a second surgery when the cystic lesion comes back. Yeah. And to prevent this radiation, there's no question. Now in Germany, it's changed. Previously everybody went to photon beam radiation. Now all children get proton beam because they said the risk for secondary malignancies or secondary tumors is less, and also the neurocognitive outcome for the kids should be much better. So it doesn't matter. It's an ependymoma, craniopharyngioma in Germany. The oncologists send all the kids to the proton beam radiation, no photons anymore.
I don't know, it's still not probably published, but Tom Merchant talked about the difference between proton beam and photon during the Singapore pediatric meeting. And they have shown that their 10-year follow-up hasn't shown much difference.
Regarding cognitive outcome? Yeah. Regarding cognitive outcome or regarding the recurrence?
No, in terms of outcome, in terms of survival as well as hypopituitarism.
Okay. As I said, the neurocognitive outcome should be better and secondary tumors should be less. That is
everybody, we now have proton beam for about 4 years now. And one of our initial experience, I have had about 8 patients treated. The response is very rapid. I mean, I've had some tumors which were seen disappear within about 7 to 8 months. But what happens long term, I think this paper should probably answer some of our questions.
Yeah.
We might move on to a couple of quick cases. So Girish asked me to prepare one case, which I think is actually quite topical to what we were discussing and Yugal mentioned. So this is a patient that I treated here in Melbourne, 41-year-old woman with acromegaly, fairly typical presentation, headache and visual disturbance, had classical acromegalic features and an IGF-1 of over 100. And this was her original imaging. She was actually treated by another surgeon at that time. You can see the obvious cavernous sinus invasion on the right side, probably NOS 3B, with normal gland well visualized superiorly and on the left, and the stalk deviated to the left. She had an initial microscopic resection in June of 2019 of the disease in the cellar and recovered well with no complications, but had clearly persistent disease with an IGF-1 of 64. Our normal range is 10 to 34, and this was 3 months post-operatively. She was commenced on octreotide, increased to maximal doses, and still had elevated IGF-1 and a slightly impaired fasting glucose. The endocrinologist was reluctant to offer pasireotide, and this was the imaging. So clear disease in the cavernous sinus, and perhaps in the medial part of the cellar. So I'd be interested in what our panelists, Ramesh and Henry, would do, and Dr. Diapujari. What would be your approach, Henry?
I would try to get more tumor out, but it can happen that it's not working. It can happen you open it and you have so much trabecula and you will not get improvement. I would explain to the patient, we have an option to improve it. If we are lucky, we can remove this. And sometimes you are lucky that you can remove quite a big deal of the tumor. And if it's not working, of course, an octreotide is not sufficient, then remains the radiation therapy with radiosurgery.
Yeah, I think I also would agree, James, that we should give surgery a second chance. But it looks like more spread out than a focal recurrence in the cavernous sinus, especially the part of the cavernous sinus that goes along the inferiorly. But if it was a soft and suckable tumor, you probably could more tumor out. But in terms of cure, it's going to be, I think it's doubtful whether you can achieve a cure. But it's reasonable to take the tumor load off before we consider any further treatment.
And Dr. Diapujari?
Yeah, I agree. I think the consistency of the tumor is pretty important. I mean, sometimes you have a softer tumor in the sella and you have a more firm tumor when you enter the cavernous sinus. And in those cases, I found that you have to probably come out. And in our center, we treat such tumors with SRS as the stereotactic radiosurgery with gamma knife as the first, rather than going for medical, and that remains an additional treatment.
Yeah, I mean, I find if it's inferior and anterior, I would generally go have a go at it. This is the post-operative. This is the intraoperative video, just removing the bone. The use of the Doppler is very helpful in my experience, opening the lateral part of the cellar and removing a little bit of tumor. It was relatively soft, which I think made it favorable, and I did discuss it with the initial surgeon. Then opening the dura over the cavernous sinus anteriorly, removing tumor from within those little trabeculae. But again, I agree, you're very dependent on the tumor consistency. And then at the end of the procedure, looked like we cleared out as much as we could, some flow seal, and rather than leave the carotid exposed, we did put a flap up over the resection cavity. Patient had a good post-operative MRI. It's always difficult to interpret, but the IGF-1 normalized 3 months post-op and has remained normal 3 years post-op. I don't think this patient is cured, but I was moderately surprised at the benefit of re-resecting, and this patient's off medical therapy as a normal IGF-1 3 years down the track. So it'll be interesting to follow her. I imagine she will recur at some point, but I think it was probably worth doing.
Yeah.
Excellent result.
Yeah, nice.
Yeah.
Very well done. But it shows that you should attempt it. I would attempt it. Sometimes you are lucky, it's working very well, like in this case, and sometimes not. But if the risk is not too high that you do something very bad to the patient, I think it's always worthwhile to get it. Excellent.
I think Thank you all. It's been a fantastic evening. Thank you all for making the time. And I'm sure everyone who's listened in would agree it's been a fascinating evening. Thank you for actively participating, and to all the participants too. Very grateful for you, to all of you, for making the time. I know it's a weekend. Some places it's the morning, and for the rest of us, it's going to be night. So with that, I'll leave you all. Thank you very much, and hope to catch up sometime soon. Thank you.
Thanks
Thank
for
you, Girish.
organizing, Girish.
Thanks for the invitation. Bye-bye.
Thank you.
Bye-bye.
Thank you, everybody.
Thanks, Girish, for organizing this.
Bye, Ventio.
Bye. See you guys.